Finally, we're going to discuss the relationship between hospitals, and then we'll end with the relationship between hospitals and payers. So we're just looking at kind of the relationship among hospitals and hospital competition. So hospital care is what is called a differentiated product oligopoly. There are strict barriers to entry, so it's really difficult to open your own hospital. You need the building, the technology, staff, administration. There's a lot of specialization and expertise involved in opening a hospital. That's why a lot of it happened, you'll remember from the last video, because Congress supported the creation of hospitals. So it's hard to enter the game now. And so when there are few firms in a market, that is called an oligopoly. It's like a monopoly, but when there's just a few rather than one. And yet, hospital care has, from one hospital to another, from Memorial Sloan Kettering to Montefiore, for example, there is some differentiation in the products and services that they're selling to you. So it's an oligopoly because there are few firms, and because the product itself is differentiated between sellers, it's called a differentiated product oligopoly. You can contrast that with the oil industry, for example. Similarly, strict barriers to entry and a few firms internationally that sell it, but the product itself is not highly differentiated. When you're buying crude oil from one versus the other, it's not as different as one hospital to another. So in this case, for hospitals, it is a differentiated product oligopoly. So a way of measuring in any market the degree of concentration is using the Herfindahl-Hirschman Index, or HHI. It's something that's used in things like antitrust litigation in a lot of contexts. So what HHI means, it's basically a sum of the squared market share. So for each firm in that market, they sell like some percentage of the total products sold in that market, and that would be that firm's market share. And when you square the sum of all of them, if it's closer to 1, that means there are very few firms in the market and that it's highly concentrated. And if it's closer to 0, that means there are a large number of firms in the market, and neither of them has any meaningful control over it. So there's limited competition in the hospital market. This is due not just to those barriers of entry that was described, but also for a couple of reasons. One is that because of insurance, prices are not very transparent. So a lot of times, like in a competitive market, price transparency would put downward pressure on prices because consumers would be able to price shop. But we don't know what the prices are. And there's also the moral hazard of insured patients. They don't have to feel the prices, so they consume more than they otherwise would. They're less sensitive to prices, and that means they're going to be less able to apply downward competitive pressure on prices. Also, in a lot of cases, government sets prices. Medicare is a really important buyer in this market, and they negotiate for what they're going to reimburse. And the emergency nature of healthcare means that a lot of times, if you have a heart attack, you're not going to price shop. You're not even necessarily going to look for the best. You're going to go to the one that is closest because time is of the essence. So there's very little room for competition and competitive pressures in the hospital market. So is this hospital competition, the limited hospital competition, or if it was greater, would that be good for patients? Like, is hospital competition good for patients? And typically in a competitive market, it's going to act to improve quality and lower price. Because if your price is too high or if your quality is too low, people will go to your neighbor. So usually competition improves quality and lowers prices. However, in this context, insurance hinders price competition, and instead hospitals are competing for physician referrals of patients. So that ends up leading to what is called the medical arms race hypothesis, that when there is greater competition among hospitals for physicians, it can result in redundancies, like redundancies in the presence of medical technology. There might be like way more MRIs than we need in New York City because these hospitals are competing for physicians, and also overconsumption of medical technologies. This can increase costs without improving quality. And so there's lots of empirical research about the effect of hospital competition on patient outcomes, and the findings have just been mixed. And the policy implications are different from one another. They're kind of contradictory. So it's really not clear that hospital competition is necessarily good for patients. In the US hospital industry, we have both for profit and nonprofit hospitals. Most are nonprofits. As of 2009, 75% of private hospitals are organized as a nonprofit. And actually, in the state of New York, for profit hospitals have been completely outlawed. Um, there are some benefits, so there's trade offs to the organization of the hospital. If it's nonprofit, um, you're exempt from taxes from the perspective of the person running the hospital. You're exempt from taxes, and donors can receive a tax deduction. But the cost of a nonprofit status is that you can't sell your stock in a market to raise equity for expansions. You can't distribute profits to owners, which people might want to use it as a vehicle for the generation and accumulation of profits. And also, you're restricted to certain kinds of charitable activities. You can't engage in all kinds of profit generation activities, and you have to give care to the poor, for example. So, why do these nonprofits exist if they have these limitations? So there are four explanations. One is that they're just being altruistic. They have this altruistic motive that some entrepreneurs prefer helping others over receiving profits. There is the government failure theory that just politics and policies have been ineffectively able to help people in need, and nonprofits have filled that space for that need that just exists in society. Another is asymmetric information, that donors tend to trust nonprofits more with their money than with for-profits, and for that reason might be might want to use that as a vehicle for their altruistic motives. But specifically on the side of the donors and their trust. And finally, it's possible that nonprofits are kind of just for-profits in disguise, that the profits are just essentially distributed as really high CEO wages or other kinds of non-monetary benefits. There are mixed results, and I think that in hospitals in particular, the state of New York did a good thing by outlawing private hospitals. In private insurance, for example, it's a little harder to tell the difference, but in hospital context, they do tend to engage in better charitable endeavors. Okay, so finally wrapping up this week, the relationship between hospitals and payers. The prices that insurance companies pay to hospitals varies greatly, even for the same surgery or procedure across different hospitals. So according to just a public list of prices, these are the charge master prices. The cost of a chest x-ray in 2004 could be either $120 or $1,520, just within the state of California for the same event. So this is really tremendous variability. But the thing is that in reality, consumers, both insurers and patients out of their pockets rarely pay that charge master price. It's the negotiation point where they start from. Instead, so hospitals and insurers negotiate with one another, both private and public hospitals, and negotiate rates every year or 2 years for the following contract period. And so rates vary relative to the bargaining power of the hospital and the insurer. So for example, if this hospital is in a rural area and the insurance company really has no choice but to cover it, otherwise their patients won't have any in-network hospital care within a reasonable distance, then that hospital has a lot of negotiation leveraging power. And on the other hand, where there's a lot of competition, then they will have less bargaining power. But if you're the star hospital and everyone, if you're the Johns Hopkins, or if you're the Brigham Women's Young, then you might have greater negotiating power for that reason. And it also depends on the bargaining power of the insurer and the volume of patients that they're able to send your way. So even the same hospital will end up at a different negotiation point with different insurers. So they can sell the same product within the same hospital to different payers and receive different rates. So prices are in hospital care are really difficult to define. Okay, so we have this phenomenon of emergency medical treatment in the United States. So if you are, regardless of what your insurance status is, if you need emergency care and need to be stabilized and you go to a hospital, you must be treated. And they cannot ask about whether or not you can pay, or like they can't, your care cannot depend on whether or not you're able to pay. So they have to bill you after the fact. But a lot of people who are uninsured will not be able to pay for a hospital bill that's in, more than $10,000, let's say. So EMTALA, the Emergency Medical Treatment and Labor Act of 1986 is what requires that. And so what happens if the uninsured patient shows up? Essentially what happens is that it's uncompensated care is what it's called. So it's what happens when the hospital charges, when hospital charges are not covered by out-of-pocket payments, by public insurance, or by private insurance. It just remains uncompensated. So the textbook argues that unpaid hospital care ends up being paid for through cost shifting, that rich patients pay for poor patients' care. It's cross-subsidized within the market. And as evidenced by the fact that in the United States, reimbursement rates are a lot higher for private insurers than they are for Medicaid or Medicare. So the hospital takes a hit from the low costs of Medicaid or Medicare, but overcompensates by overcharging the private insurance companies. And that way they can kind of break even once they also incorporate the uninsured. However, when there was Medicaid expansion in a lot of these states, the number of uninsured declined by a lot. In particular, hospitals, charity care or teaching hospitals in rural areas who had large numbers of uninsured patients, or a large share of their patient population had no coverage. And then they gained coverage through Medicaid expansion. Those people go from essentially being able to pay zero or very little to at least having the majority of their stay covered. And when that happened, you would think that would reduce the burden that they would need to make up from their privately insured patients. But it turns out they just go right on ahead, charging their privately insured patients whenever they want, or at least far higher than what you would assume they were doing. If they were actually making that calculation, then it would they would pull it back. But instead, they're essentially just charging whatever they can get away with in that negotiation process. So there is this phenomenon of uncompensated care, and there is uncertainty about how that care ends up getting covered. There is kind of a conventional wisdom that the reason that they charge private insurers so much money for this healthcare is so that they can make up for uncompensated care, but it's not very clear.